Hello everyone. In today's lecture, we are going to focus on depressive disorders, one of the most important topics in abnormal psychology. Here is the outline for this lecture. First, we will begin by asking a basic question. What are depressive disorders? We'll define them and look at how they are classified. Second, we will examine the key features of depressive disorders. Third, we will explore the causes and risk factors. This includes biological, psychological, and social factors that contribute to the development of depression. Finally, we will look at support and intervention, how depressive disorders can be treated, and what kind of approaches are available to help people recover. Let's begin by asking a simple question. What exactly are depressive disorders? First, it is important to distinguish between melancholy and depression. Melancholy refers to a temporary state of gloomy or heaviness, often accompanied by a lack of energy. This includes feelings of sadness and distress, which are common human experiences. Everyone feels down from time to time, and this does not necessarily mean a person has a psychological disorder. However, depression as a clinical disorder, what we call depressive disorder, is different. It involves a persistent low mood lasting for at least 2 weeks. This is not just about having a bad day or feeling sad for a short period. As you can see in this chart, everyone experiences sad mood from time to time. For example, when we go through events like loss, failure, and disappointment, our mood naturally drops. However, for most healthy individuals, this sadness is temporary. After a while, their mood returns to normal and they are able to continue with their daily lives. In contrast, with a depressive disorder, the low mood does not simply become bounce back. Instead, it persists and often becomes deeper over time. Even after 2 weeks or more, the individual continues to feel down, lacking energy and motivation. And as for depression, the emotional experiences go beyond sadness. They may include anxiety, fatigue, emptiness, apathy, or irritability. One of the key features of depression is the marked loss of interest or pleasure in daily activities. For example, a person might stop enjoying hobbies they used to love, or they may withdraw from social interactions. On the right side of the slide, we can see the major category of depressive disorder listed. These include major depressive disorder, persistent depressive disorder, also known as dysthymia, disruptive mood dysregulation disorder, premenstrual dysphoric disorder. These categories help clinicians diagnose and distinguish different patterns of depression depending on how symptoms appear and how long they last. Now, let's look at the key features of depressive disorders. We have major depressive disorder or MDD here, 주요 우울 장애. The most central characteristics of MDD is a loss of interest and pleasure in life. This is often called anhedonia, and it is one of the most reliable signs of clinical depression. Along with this, there are several common symptoms. First, a loss of energy makes it difficult to complete daily tasks. For example, students may find it hard to finish assignment or even get motivated to start new tasks. Second, sleep disturbances are very common. Some people may sleep far too much, while others suffer from severe insomnia. These problems often come with weight changes, poor concentration, and sometimes cognitive impairment. Finally, some individuals may struggle with suicidal thoughts, which represent one of the most serious risks of depression. These symptoms go far beyond just feeling sad. They interfere with everyday life, work, school, and relationships. There are also important patterns and risk factors to keep in mind. First, depression is more common in women, about 1.5 to 3 times higher than in men. Many people with depression are able to return to normal functioning after recovery, but in some cases, it can become chronic, especially when it occurs alongside with anxiety disorder, personality disorders, or substance use. In adolescents or those with family history of mood disorder, this depression can sometimes develop into bipolar disorder. Another clinical point is the high risk of suicide. The strongest predictor of suicide attempt is a history of past attempts. Risk is also higher among men, people who are unmarried, and those who experience intense feelings of hopelessness. Additionally, individuals with borderline personality disorder face an increased suicide risk when depression is present. Understanding these features help us see why depression is such a serious mental health issue and why careful assessment and early intervention are so important. Major depressive disorder is not the same for everyone. In fact, it can appear in different forms, which we call subtypes of MDD. Let's go through these subtypes. First, melancholy type. This form is characterized by a loss of pleasure in almost all activities. The person does not even respond to things that would normally bring joy. Symptoms often include feelings of deep despair, worse mood in the morning, wake up early, loss of appetite or weight, and excessive guilt. And with psychotic features, in some cases, depression can be accompanied by delusions or hallucinations. This may be consistent with mood, for example, hearing voices and reinforced feelings of guilt, or inconsistent with mood. And atypical type, unlike the melancholy type, people with atypical depression show mood reactivity. Meaning they can feel better temporarily when something positive happens. Common symptoms include appetite or weight gain, excessive sleep, and a heavy feeling in the limbs and sensitivity to rejection in relationships. And catatonic type. This subtype involves disturbances in movement. A person may remain immobile, show strange postures, or experience agitation. These symptoms go beyond the mood and affect physical activity. And postpartum onset. This refers to depression that occurs during pregnancy or within 4 weeks after giving birth. This is often known as postpartum depression, and it can have significant effect on both the mother and the child. And lastly, seasonal pattern. Sometimes called seasonal affective disorder, this form of depression appears at certain times of the year, usually in the fall or winter, and tends to improve in the spring. It is thought to be related with changes in light exposure and biological rhythm. So, as we can see, depression is not a single uniform experience. Understanding these subtypes helps clinicians provide more accurate diagnosis and tailor treatment to the individuals. Now let's move on. Persistent depression disorder, also called dysthymia, 지속성 우울장애. Compared to major depressive disorder, dysthymia is generally milder in severity, but the key difference is its chronic course. To meet the criteria, some symptoms must last for at least 2 years. The symptoms include poor appetite, or in some cases overeating, sleep problems such as insomnia or hypersomnia, lower energy and persistent fatigue, poor concentration and difficulty making decisions, low self-esteem and feelings of hopelessness. While these symptoms may seem less severe than those in major depression, the long-lasting nature of dysthymia makes it very impairing. People may function day to day, but they often feel as though life is joyless and exhausting. In the DSM-4, we had 2 separate diagnoses. Chronic MDD and dysthymia. However, in the DSM-5, these two were merged into one category called persistent depressive disorder. Now, sometimes we see a situation where a person who already had dysthymia develops a full major depressive episode on top of it. This is referred to as double depression. It means that dysthymia is the baseline condition and then an episode of major depression occurs during that time, and it tends to be especially difficult to treat. Dysthymia is also comorbid with other conditions such as borderline personality disorder and substance use disorders. This course of the illness is chronic and variable, meaning it can last many years, sometimes for most of person's life. Interestingly, the prognosis may actually be worse than MDD because of how persistent and unrelenting the symptoms are. So even though dysthymia looks milder on the surface, its long-term impact can be extremely significant. Next, let's look at the disruptive mood dysregulation disorder, or DMDD. 파괴적 기분 조절 부전 장애. This disorder is characterized by severe chronic irritability in children and adolescents. The key symptom includes frequent temper outbursts that are out of proportion of the situation, a persistent irritable or angry mood between outbursts, symptoms that last for 12 months or longer. This is more than just being moody. Children with DMDD experience irritability so severe that it disrupts daily life at home, in school, and with peers. DMDD was introduced in the DSM-5 to help distinguish it from pediatric bipolar disorder. In the past, many irritable children were misdiagnosed with bipolar disorder, but research showed their symptoms were different. Some important point to note: the onset must occur before age 10, and the diagnosis is not made by children younger than 6. It is more common in boys in school-age children. Children with DMDD often go on to develop depressive or anxiety in adolescence and adulthood. Severe irritability also has a big impact on family life, peer relationships, and school performance. In most serious cases, it can involve aggression, self-harm, or even require hospitalization. So DMDD is not simple about having a bad temper. It reflects a chronic patterns of emotional dysregulation that can lead to long-term mental health difficulties. The last depressive disorder we will discuss is premenstrual dysphoric disorder, or PMDD. This condition involves severe emotional and physical symptoms that occur before menstruation. Unlike typical menstrual symptoms, PMDD is much more intense and significantly interfere with daily life. The key symptoms include emotional symptoms such as mood swings, irritability, depressive mood. Women with PMDD often describe feelings out of control or overwhelmed by these emotions. Anxiety and low interest in activities, which makes it difficult to stay engaged in school, work, or relationships. Physical symptoms, including blurring, breast tenderness, or headaches, which add to emotional burden. It is important to emphasize that PMDD is not the same as ordinary premenstrual syndrome or PMS. PMS is relatively common and usually manageable, but PMDD is more severe and classified as depressive disorder because of its impact on functioning and mental health. Recognizing PMDD is crucial because it often goes undiagnosed, and yet effectively treatment such as lifestyle change, medication, or therapy can greatly reduce its impact. In this section, we will look at why depressive disorder develop. There isn't a single cause. Instead, depression emerged from an interaction of biology and psychological factors together with life stress. Here is a simple framework. On the biological side, we will consider stress system dysregulation and brain's reward circuitry and neurotransmitters. On psychological side, three classical perspectives help us understand risk: psychoanalytic approach, cognitive approach, and hopelessness theory. Let's start with biology. Two systems are especially important: HPA dysregulation and reward system deficit. Chronic stress can overactivate the HPA axis, leading to elevated stress hormones and heightened negative emotions. At the same time, reduced activity in the nuclear accumbens, a core part of the brain reward system, blunts pleasure and motivation. These helps explain anhedonia, the loss of interest and joy. Next, neurotransmitters. Imbalance in serotonin, norepinephrine, dopamine are often observed in depression. Many antidepressant medications work by increasing these neurotransmitters in synapse. When that happens, symptoms typically improve over time. It is important to remember that depression isn't just chemical though. These chemicals operate within broader brain circuit and are influenced by stress in learning. According to psychoanalytic perspective, depression can be triggered by the unconscious processes that occur after the loss of loved one. The individual may regress to an earlier developmental stage and merge their sense of self with the lost person. Sadness and anger toward the loved one then turn inward, which deepens the depression. Importantly, this mechanism does not only apply to real loss, it can also be activated by imagined or symbolic losses. The cognitive approach emphasizes the role of dysfunctional beliefs in the development of depression. These are negative and distorted ways of thinking about oneself and future. For example, someone may believe I'm worthlessness or I will never be loved. Other common dysfunctional thoughts include my future is bleak or hopeless or my situation is unbearable. These kinds of beliefs maintain and intensify depressive symptoms. Hopelessness theory, proposed by Abraham and his colleagues in 1989, suggests that depression arises from negative expectation and sense of helplessness about important outcomes. People with dyspressionic attributional style, meaning they attribute failures to internal, stable, and global causes, are more vulnerable to depression when facing stress. For example, a student might think, I failed this exam because I'm incompetent. I will always fail. My whole future is ruined. This style of thinking magnifies the impact of setbacks and fuels feelings of hopelessness leading to depression. Now, let's move on to the next topic, support and intervention for depressive disorders. As you can see on this slide, treatment for depression usually involves a combination of approaches. First, pharmacotherapy refers to medication. This includes tricyclic antidepressants, 3한계 항우울제, which were among the earlier drugs developed, and SSRI, selective serotonin reuptake inhibition, which are the most widely prescribed today. In some cases, neurobiological treatment like transcranial magnetic stimulation, TMS, 경두계 자기 자극술 may also be used to regulate brain activity. Second, we have cognitive therapy. This approach aims to identify and correct distorted or dysfunctional beliefs that contribute to depression. For example, someone might think I'm worthless or things will never get better. Cognitive health clients replace these thoughts with more balanced and adaptive thinking patterns. Finally, behavioral therapy focuses on changing daily habits and actions. Techniques include self-monitoring through daily activity log, setting gradual and realistic tasks to re-engage with life, and practicing assertiveness so individuals can express themselves more effectively. Together, these treatments address both biological and psychological aspects of depression. In this section, we explore the landscape of depressive disorders. We begin by defining major depressive disorder and examining its subtypes. We then look at the persistent depressive disorders or dysthymia and considered its chronic causes and risk for double depression. We also covered disruptive mood dysregulation disorder in children and adolescents and premenstrual dysphoric disorder with its emotional and physical symptoms. Next, we turn to causes and risk factors. We considered biological mechanisms such as HPA axis dysregulation and reward system deficit and neurotransmitters imbalance. We also examined psychological factors including psychoanalytic view of loss, cognitive distortions and dysfunctional beliefs, and the hopelessness theory of depression. Finally, we discussed interventions, treatment approach including pharmacotherapy with antidepressant medication and somatic method like TMS, cognitive therapy to restructure maladaptive thoughts, and behavioral therapy to encourage activity, skill, practice, and assertiveness. Across these disorders, several themes stand out. Depression is common, multifactorial, and often recurrent. But outcomes improve with comprehensive care that combine biological, psychological, and social support. I hope this lecture has helped you gain a deeper understanding of depressive disorders and their treatment. Thank you for your attention.